Hello, everyone. Welcome to our Point of Care Ultrasound webinar series from GE Healthcare. So today's topic, what we're going to do is ultrasound for vascular access, basics and beyond. And it will be done by our speaker from Singapore, Kutek Hospital, Dr. Kumaresh Venkatesan. As you can see the slides on your screen right now, we put our venue go on a ceiling mounted. This is in fact our first venue go installation, which is ceiling mounted on Hospital Sungai Buloh in Malaysia, which is currently the #1 hospital to treat COVID-19 patients. So going back to our ultrasound webinar series, maybe I should start with introducing myself. My name is Kamarul. I'm the clinical product manager for Point of Care Ultrasound ASEAN for GE Healthcare. So you can see on screen, I put in my email address, my Facebook account, my LinkedIn account, and also a general YouTube account for GE Healthcare. So if in case you have any inquiries or anything you want to inquire about our product today, about the webinar today, anything, you can just reach me out on my email, Facebook, or LinkedIn account, whichever you are comfortable with. So just let me know. I'll try to answer all your questions or inquiries. So being based in Malaysia, I cover ASEAN, to be exact, 10 countries. Majority of it I cover for emergency critical care anesthesia department. So we've done a lot of support across the region before the pandemic. So we've supported Dr. Philip Mackay, an anesthetist in Hanoi, Vietnam, for his RA diploma program earlier this year. And then we also last year we supported ASEAN Congress of Anesthesiologists in Brunei. And then we also loaned our ultrasound machine to the sports physician from Malaysia at the SEA Games in Manila, Philippines. And we also supported the International Symposium for Ultrasound in Regional Anesthesia and for INSURA in Manila. So we've done a lot of workshops throughout. We've supported a lot of workshops. We supported a lot of events. We try to get as much as feedback from you guys. So we try to make sure we are doing the best to support. So with that, I would like to say thank you for giving us the opportunity to support your event and continuously give us the opportunity to support any of your events. So if you do have any inquiries, any thing related to what we're doing, just drop me an email. I'll try to support as much as possible. So before we start our webinar, let me introduce our speaker. The speaker is Dr. Kumaresh Venkatesan. He's the senior consultant in anesthesia and intensive care at Ho Teck Puat Hospital in Singapore. So after obtaining the postgraduate anesthesia training from India, he completed specialist training CCT in anesthesia and intensive care in UK and worked as a consultant in #1 Trauma Center before moving to Singapore. He is a fellow of Royal College of Anaesthetists and Faculty of Intensive Care Medicine UK. He also has a focus intensive care ECHO UK accreditation in point of care ultrasound. So now we move over to our speaker and start our webinar series, Ultrasound Vascular Access, Basics and Beyond. So Dr. Kumaresh, you may take over the floor.
Thank you.
Yep, continue, please.
Can you see my screen?
Yep, it's... Yeah, okay. Hold on. Okay, yeah.
Can you see my screen?
Yep. We can see your screen. Yep.
Okay. Shall I start?
Yes.
Okay. Good afternoon and warm welcome to all those who have sacrificed your Saturday afternoon to join for this webinar. And thank you, GE, for your effort in organizing this webinar. And thanks again for inviting me this afternoon to talk about the ultrasound for vascular access, basics and beyond. When I started...
Hold on. We had an issue. Can you... Yeah, we cannot see your screen. Something lost. Can you share, present again? Present. Yeah, can you present? Yeah, we are not seeing your screen.
Not seeing, is it? Okay, hold on.
Yeah, can you try again?
I'm going to cancel and come back again.
Yeah, yep. Can you stop sharing? Then try to press present now and
Yeah.
present entire screen. Yeah.
Present entire screen.
Yes.
Can you see me now?
Okay. Yes. Yep. It's loading. All right. It's loading. Yep. Okay.
Okay.
Awesome.
Okay, let me start again.
All
Okay.
right. Yes. Thank you.
Okay, good afternoon, everyone. Thanks for joining for this webinar. And thanks again, G, for organizing this webinar and inviting me to talk on ultrasound for vascular access, basics and beyond. The point-of-care ultrasound device for vascular access was introduced in clinical practice about nearly 25 years ago. And this was the first generation of point-of-care ultrasound device, which I used as a trainee about 15 years ago for vascular access. As you can see, things have evolved quite a lot. Okay, the technology has improved, the equipments have improved, they're far better now. What we now has what I call a fourth generation devices. What we use in our unit is the GE Venue point of care ultrasound machine. And this has enabled us to push our boundaries as well. The outline of this afternoon's presentation is going to be as follows. I'm going to start with talking about indications, advantages, and talk about some evidence base, and go through the vascular anatomy, and then talk about optimizing the image acquisition. How do we see the vessel? How do we manipulate the transducer and see the needle? And then some examples of real-time cannulation. So when we started 30 years ago, how did we perform central venous cannulation? We used a landmark technique. We only used a point-of-care ultrasound when it was very difficult or we're in a clinically challenging situation. But when we started using ultrasound, we realized that the problem with the landmark technique was the complication rates were quite high, about 20%. And when we started using in real time, we realized that we were able to get a good anatomical guidance to perform the cannulation. We were able to see the vessels, whether they were patent or not. And thereby, we are able to minimize the attempts to perform the procedure and reduce the complication rate. So the ultrasound provided us a window for the patient's vascular anatomy. So from the habit of using it for a difficult patient, we now recommend the use of ultrasound for all vascular access procedures, the central venous cannulations. Looking at the evidence, this was the first paper which was published in 1986 from a group in Japan, where they presented a series of about 160 patients where they were able to successfully cannulate the internal jugular vein without any complication. It took another 10 years for this first meta-analysis to be published in Critical Care Medicine, and subsequently a lot of papers came out, all of which supported the use of ultrasound for vascular access, mainly for internal jugular venous cannulation. But as we clinicians became more familiar and the equipment and the technology improved, we stretched our boundaries and we started using for other central venous cannulation procedures as well. And now it's recommended for all central venous cannulation procedures. But how is the uptake? Okay, this is a recently published paper, Intensive Care National Audit Project group, which published about what is the state of uptake of ultrasound use for the vascular access procedures, the central venous cannulations. This study was performed about 3-4 years ago, was published a couple of years ago. At that time, about 93% of the cannulations in UK were being performed using ultrasound. The remaining 7%, they did not have access to the device. Okay, that was the reason why they didn't. And even with the use of ultrasound, what they found was the complication rate was still quite high. And the main reason for that was, one was a lack of experience in using the ultrasound. And then the other issues were not visualizing the needle during real-time ultrasound guided insertion, and not visualizing the guide wire. These were the three main reasons they attributed to the high complication rate. So we will talk about how we can overcome these issues and be able to perform the cannulation safely. Moving on, I'll just give you a quick overview of the anatomy of the vessels which of interest to us. The three main central veins are internal jugular vein, the subclavian stroke axillary vein, and the femoral vein, and then we do cannulation in the peripheral vessels as well. Okay, when we talk about the internal jugular vein, we know that the vein lies in the neck underneath the sternocleidomastoid on either side, and it runs along the along with the carotid vessels, and then it goes down where it joins with the subclavian vessels. Again, when you're the relationship of the vein to the artery changes along the course of the vessel, and the procedurists have to bear that in mind when you're planning to perform the procedure in order to carry the procedure safely. The next vessel of interest is the axillary or subclavian vein. As you can see, the basilic vein, which comes from the arm, joins with the brachial vein to form the axillary vein. And the axillary vein, when it reaches the outer border of the first rib, then it becomes subclavian vein, and it goes underneath the clavicle, then continues as a subclavian vein, and then joins the internal jugular vein. Now, because the subclavian vein goes underneath the clavicle, it becomes a challenge to visualize it using the ultrasound. So that's why we often use the axillary vein. And here you can see the axillary vein along with the axillary artery lying infero-lateral to the vein. You can also see this the cephalic vein coming and joining the axillary vein at this point. When you, again, when you're performing a real-time cannulation, my advice would be to stay away from this point, so puncture either proximal or distal to the point of entry of this cephalic vein. Femoral vein, okay, this picture shows a left-sided femoral vein and the adjacent structures. Again, the anatomy is the below the inguinal ligament, a few centimeters below the inguinal ligament. You can look for the femoral vein. We know that the vein lies medial to the artery. The other important structure of interest to us is the saphenous vein, which again comes and joins the femoral vein. Again, and when you do the scanning, you can see this what looks like a Mickey Mouse head sign. So that's the saphenous vein, femoral vein, and the femoral artery. Again, if you're doing cannulation, try and avoid entering this point, because again, because of the presence of valve at the junction of saphenous vein, the cannulation may be problem. Okay, so either puncture the vessel either above or below the point of joining of the saphenous vein with the femoral vein. The other upper extremity vessels which is of interest to us is the basilic and the cephalic vein and the brachial artery for if you are to perform arterial cannulation. Sometimes we use forearm perform cannulation in patients with difficult peripheral venous access. And then the basilic and the cephalic vein is of interest, especially for those who are performing using the basilic vein for insertion of PICC lines or PICC lines. So again, you need to be aware of that. If you're using cephalic vein, you need to know that it goes and joins the axillary vein, and sometimes that can cannulation and advancing catheter can be a challenge if you choose to perform the use the cephalic vein. Okay, so moving on from the vascular anatomy, we talk about how do we obtain the best image. If you're using a digital SLR camera, you want to obtain a best picture, you want to know what's the lens you're going to use, what's the exposure, what's the shutter speed, those type of things you decide before you're taking the picture. Similarly, we need to know a few things to how to obtain a good quality image when we are using the ultrasound. First is the transducer. For vascular ultrasound, we use the linear probe, high frequency probes. The problem with the linear probes is, depending on what probes you perform, they can have a long footprint or a large footprint, and sometimes that can cause problem, especially if you're performing long axis view. Some of the equipments come with the shorter footprint transducers. The other transducers which is of use, which I find of great use, is this the microconvex transducers. If you can see, the footprint of the microconvex transducer is only about half the length of a linear transducer, and that is actually quite useful when you're performing in difficult patients with limited space in either in the neck or other areas. The other advantage with a microconvex probe is it has got a greater penetration and better resolution to visualize deeper structures. When you're performing the procedure real time, it's imperative to make sure that you have use the sterile sheet to maintain absolute sterility. Most of the machines, when you turn on, there is a default depth setting. Again, when you obtain the image, my advice is to optimize the depth so that you only want to see the vessel which is of interest to you. So adjust the depth setting so that you can sort of magnify the view, and it also makes the visualization of the needle and the guide wire better. Okay, so adjust the depth settings, optimize the depth settings before you start the procedure. Gain. When we talk about gain is relates to how you adjust the brightness of the image. We have the near gain and the far gain. The optimum gain which I would recommend is such that you have the image not very dark and not very bright, and it allows the visualization of the needle tip. So I often start with the auto gain and then I adjust it depending on the quality of the image. We talk about transducer orientation and display setup. Most of the ultrasound, the probes, they have this palpable orientation marker that matches with this marker on the screen, display screen. Now it's important for you to align the orientation of the probe to anatomical orientation of the area of interest. What do I mean by that? If you're performing in this animation, if you're performing femoral venous cannulation, the anatomical orientation is such that if you're doing on the right side, we know that the vein is on the medial side and the artery is on the lateral side. And I want to orient the probe such that I want to see the vein on the right side of the screen and the artery on the left side of the screen. So make sure you orient the probe so that you can see what you conceptualize in your mind, especially when you're standing at the foot end of the patient and performing. This is the image you would want to see on the screen. Why is it important? When you're doing real-time cannulation, having the correct orientation is vital when you are manipulating and advancing the needle in order to minimize the mechanical complications. Okay, so that's about setting the machine and optimizing the images. Now I'm going to talk about vessel visualization, transducer manipulation, and needle visualization. Before I go on to that, remember in the earlier presentation, on the earlier slide, I talked about the high incidence of mechanical complication in a recent study. And what I found was especially the novice users have problem with using the transducer and visualizing the needle. So recently, they have come up with this 6-step guidance, which enables safe performance of real-time ultrasound guided cannulation. And by adhering to this stepwise approach, we will be able to safely manipulate the transducer, visualize the vessel, and perform the real-time cannulation, thereby reducing the complications. So let's go through this 6-step approach to perform real-time cannulation. To start off, identify the anatomy of insertion site and localization of the vein. Identify the vein, the adjacent artery and other structures. Look for any anatomical variations. Decide whether you want to do short axis or long axis. I would recommend to get both views and decide which one you want to go for. And then it's important to perform this procedure before you clean and drape the patient. Another concept which has now come up is for every patient, before you identify and pinpoint which vessel you're going to go for, do this rapid central vein assessment, which it takes about a minute to perform. It needs to be performed on both sides. For very useful in both elective and emergency setting. You start with the middle of the neck, go down the neck, and then look at the just above the clavicle near the suprasternal notch, and then look up in the suprascapular area, supraclavicular area, and then infraclavicular area. You can also look at the lungs, make sure there's this is to compare before and after the procedure to exclude or confirm presence of pneumothorax. I would recommend the 8th step on this procedure. The 8th would be to look at the femoral vessels. Now, by performing all this, you can decide which vessel you're going to go for, and thereby you can perform the procedure safely and minimizing the complications. Okay, so as I said, you start off with the middle of the neck, where you will see the jugular vein and the accompanying artery, and then you go down the neck. You can see the again jugular vein, but if you notice the middle of the neck, often the jugular vein is covered by the sternocleidomastoid muscle. When you come down, it becomes more superficial, especially between the heads of the sternocleidomastoid, the clavicular and the sternal heads. The vein is quite superficial, but you may also see the underlying subclavian artery where it runs underneath to go and join the internal carotid, become the brachiocephalic. So that's at the lower part of the neck. And then if you tilt the probe so that it's now looking almost at the foot of the patient, then you start to see this confluence of the internal jugular joining the subclavian vein, and then which is continuing as the brachiocephalic vein. And this view is quite useful, especially once you have inserted the guide wire to confirm the guide wire. We'll talk about it in the later slides. Then you can move the probe laterally above the clavicle in the supraclavicular area, where you can look for subclavian vein. The subclavian vein can actually be seen very well in this patient, in this area, but may not be very well seen in all patients. And then moving below the clavicle, you can see the transverse view or the short axis view of the axillary vein and the adjacent axillary artery. And then if you can rotate the probe 90 degrees, keeping the vein in the middle, you will see the axillary vein. And you can perform a lung ultrasound to make sure there's no pneumothorax before you started the procedure. And then you go and look for the femoral vein. So if you can perform this, you can decide which is the vein you're going to go for, and thereby avoid complications. The other thing you need to decide also when you do this screening is identify an area which is not overlying the artery. In this example, you can see the internal jugular vein. In this area, it overlies the artery. And again, if you see that, go along the length of the vein and see the relationship, whether the relationship between the artery and the vein changes, and then choose the vessel to puncture the vessel where the vein is not overlying the artery. In that way, you can minimize complication. I've seen trainees performing the procedure where they go through both the anterior and posterior wall and end up puncturing the artery, especially in patients who are a bit hypovolemic. Okay, so the next step in this stepwise approach is the confirming the patency of the vein. How do we confirm? You can use the compression method, compress the vein to exclude the venous thrombosis, and also differentiate between the vein and the artery. We'll talk about that. And then you can use the color Doppler imaging and the Doppler flow measurements. All of this help you to differentiate and confirm the vein from the artery. So the artery is hypoechoic, but it's pulsatile, non-compressible, and there's a distinct arterial pulsatile flow when you do the Doppler flow. Vein is hypoechoic, but it's non-pulsatile and compressible, and also has a distinct Doppler flow. Okay, so sorry. So going back, so check for compressibility of the vein, and then if you do the color Doppler, you see this distinct pulsatile flow in the artery, whereas the vein, you see this continuous flow happening. And then you apply the pulse wave Doppler, you see this distinct arterial flow, and you can measure the flow velocity as well. And in the vein, you can see the distinct venous wave with the low venous velocities. You can see, again, this helps to differentiate between the arterial and the venous vessels. The other use of looking for the vessel is to see whether there are any big clots present. In this patient, you can see the clot almost filling the whole of the internal jugular vein. If you find this, you will have to go and look for another vein, another site to perform the cannulation. Again, this is why it's important to do the stepwise approach so that you know which vessel you're going to look for or go for. Another patient doing a screening ultrasound. what you can see is there's only an artery. You can't see a vein. This patient had a patient with end-stage renal failure, had previous tunnel line inserted. So the internal jugular vein was thrombosed and we could not visualize it. So we had to go for a different site. The other thing, sometimes if you see a jugular vein smaller than the artery, again, you stay away from that. That's a sign that it's going to be, the procedure is going to run into trouble. So if you have other good sized vein on other areas, then go for it. So this, again, it's useful. If you do this screening ultrasound before you start the procedure, you can decide where you want to perform the cannulation. Okay, now we'll talk about the real-time ultrasound guidance for puncture of the vein. You need to use absolute aseptic technique. You can use whether short axis out of plane technique or long axis in plane technique. We'll talk about that. The key is the important for the success of this technique is can't always keep the continue to look for the tip of the needle as you approach the vein and you puncture the vein. That is the most important step in the whole procedure, I would say. And when people don't follow this, they run into complications, and that's when you either puncture the underlying artery or you go and cause pneumothorax. So it's very important to constantly look for the tip of the needle and follow the needle. There are two views you can use. This is the transverse plane view, commonly called a short axis view, which allows you to look at the whole circumference of the vein, and it also allows you to see the adjacent structures which lie near the vein, the artery and the other nervous structures, the pleura, etc. The view is the longitudinal plane or the long axis view, where you only see the target vessel of interest. So you start off with the short axis view, and then you rotate in to get the long axis view. How do you needle this? Again, it depends on the short axis or long axis. In the short axis, the commonly used method is the out of plane needling technique, and for long axis, you use the in plane needling technique. There is a third technique which I'll talk about in the later slides. Okay. Now, which is better, the short axis or the long axis? There's one study which is published which showed that using the long axis technique shortened the time for cannulation, fewer needle directions, and fewer posterior wall penetrations. But my personal experience, I'm sure people who have done will agree with me. For a beginner, usually for them to learn the probe handling technique and the needling technique, they find the short axis useful before they become before they advance and progress to the long axis cannulation technique. This slide just gives you a summary of the sites of insertion, what are the views you can obtain, different views, and different methods you can perform cannulation. So for internal jugular vein, you can either do a transverse or the short axis view or the long axis view. And the third technique for internal jugular vein is the oblique view. Subclavian, again, the long axis is recommended, long axis in plane. Axillary vein, you can do either short axis or the long axis, again in plane or out of plane technique. Femoral vein, usually the transverse or the short axis view with out of plane technique. The brachiocephalic technique is, again, it's a difficult technique to be used only by the experienced people, which is again from the supraclavicular approach. You can either cannulate the subclavian vein, or the if you follow it down, you can perform the brachiocephalic. It's more, it can be done easily in the pediatric population. So all these, the subclavian, axillary, they all require, they're not a technique for the beginners. beginners should start with the internal jugular vein and femoral, and then they progress to axillary and subclavian vein. Okay, so this is just a slide about the oblique view technique. So you start off with the short axis transverse view, and what you need is slightly rotate the probe by about 10-15 degrees. You still see this what looks like a short axis view, and then you can insert the needle and do a in-plane technique. So this is what's called as the oblique view. This can be used for internal jugular vein cannulation. Okay, just as I want to stress about the importance of performing when you're performing the procedure, maintaining the operator and the equipment orientation. Just like how this person performing the billiards maintains the view in line. The person, the operator who's performing the real-time ultrasound cannulation, the hand holding the ultrasound probe and the needle, and the monitor, they all should be in this. Okay, that's very crucial. Otherwise, you run the risk of causing problems like Mr. Donald Duck. Okay, you'll run into trouble. Okay, now moving on, let's talk about the various terms used for manipulating the transducer. We have this sliding where you move the probe along the axis of the vessel to decide which is the point for cannulation, and you can also slide to identify the anatomical relationship of the vein with the adjacent vessels and the structures. So that's when you say slide, you either go along the vessel or slide across to look at the relationship of the adjacent vessel. And then rotation, where you rotate the probe 90 degrees to get switch between the short axis and the long axis views. Compression, you do it to identify whether it's a vein or artery. Tilting, where you hold the probe and then you gently tilt the probe. Very important maneuver when you are following the needle, when you're performing the real-time cannulation. When you want to see the advancing needle tip, this is a very important maneuver to perform. How do you hold the needle? This slide illustrates the different ways people hold the needle. When I started performing, initially I started from the landmark technique. The landmark technique holds a syringe with a needle attached to it. And when I started performing ultrasound guided cannulation, I started with this way of holding the syringe and needle. And what I realized was that the force you apply to make the needle puncture and to advance needle, it causes a lot of distortion of the image in the ultrasound machine. This is another method which has been advocated to where you hold the syringe and the needle like a pencil. In that way, you can control the amount of force you apply when you're making the skin puncture and when you're advancing the needle. And I find this technique quite useful. Something for the users to consider and adapt. Most of the interventional radiologists, if you observe them doing, they use this method. They in fact don't attach a syringe. Sometimes they just use a needle and go and perform the puncture of the vessel. Okay, this complex looking slide, I just wanted to illustrate two points. How do we decide the skin entry site? Okay, how I decide is I look at what is the distance from the skin and the vessel entry site, or the distance between the skin and the anterior wall of the vessel. And I use the same distance from the midpoint of the probe, use the same distance to make the skin puncture. Why do I do that? In that way, the the angle of my advancing needle is about 45 degrees, and that mathematically just gives me an idea of how far I have to advance the needle before I enter the vessel. And if I'm going beyond that, it tells me that I am in the wrong point, I'm not progressing correctly. I will have to stop and reassess the situation. So that's why I use the method. So it's just to repeat, it's just the depth from the skin to the point of entry to the vessel. You use that distance to decide where you make a skin puncture. So from the midpoint of the probe to the point where you make the skin puncture. This is more applicable when you're doing a short axis out of plane method. Few points about how to look at the needle. Okay, the beam, the ultrasound beam thickness is only about 1 millimeter or so. So you're going to only see the needle only when the needle comes in contact with the ultrasound beam. There are two parts to the needle. One is the bevel and the shaft. The bevel or the needle tip is the most echogenic and can be seen very well on the screen. And it's also important for the bevel to be facing the ultrasound probe for it to be seen very well on the image. The wider the bigger the needle, the bigger the gauge, the needle is better visualized. The other important thing which makes the visualization of the needle better is how steep is the angle between the needle and the transducer. What do I mean by that? So when the ultrasound probe transmits sound waves, the sound waves get reflected, and these reflected waves are transmitted as images. As you can see, when the needle is almost 90 degrees or almost parallel, a lot of waves, the waves are reflected, the needle will be seen better. But as the needle gets steeper and steeper, less ultrasound waves are reflected and returned back to the probe. So the visualization of the needle becomes more and more difficult. There are methods to improve this. We'll talk about in the next slide. So in this angle, unfortunately, the bevel reflects more ultrasound waves back to the probe. That's why the tip of the needle often appears as a bright spot compared to the shaft of the needle. Okay, because the cutting edge of the bevel reflects more waves, that appears as a bright spot, more brighter than the shaft of the needle. And you also see this acoustic window behind the shaft of the needle, because when the ultrasound waves hit the shaft of the needle, the waves are all diffracted, scattered everywhere. Some returns back to the probe, some gets diffracted, and that's why the shaft doesn't appear as bright as the tip of the needle. And then you also see this acoustic window. Okay, just illustration, just some animation to show how to manipulate the transducer when you're advancing the needle. So in the left of the screen, you have this simulated ultrasound screen, and now we are using a short axis view. So the probe looking at the vessel, so that's the vessel. And what we see is the short axis view of the vessel, and now we are approaching it with the needle. So once you make the skin puncture, you use the probe, go and look for the needle and the shaft, the tip of the needle and the shaft of the needle. And then you use this jiggling motion to distort the tissue to see whether the tip of the needle is. And again, you tilt the probe back and forth so that you're constantly looking for the tip of the needle. And as you advance the needle, again, you slide the probe, look for the tip of the needle, and then if you need to redirect, you can redirect the needle. And you need to constantly follow the steps until you reach the anterior wall of the vessel. Okay, so this is the crucial step when you're performing the procedure if you were to avoid any complication. Okay, so always look for the tip, the needle tip, and do not advance the needle. If you're not able to visualize the needle tip, go back, look for the needle tip. Once you identify the needle tip, then advance the needle. Now, as I said, the shaft may not be seen very well, okay, because so if you want to improve the visualization of the shaft, one of the methods you can do is you tilt the probe so that the ultrasound beam hits the shaft of the needle at 90 degrees. In that way, you can improve the visualization of the shaft. It makes it appear more brighter, and that will again improve the visualization, and we can perform the procedure safely. And what I call that is the to and fro method. So as you why do you say to and fro method? So when the needle, once you made the skin puncture, when the needle is advancing, you have this to and fro motion of the probe tilted at 90 degrees, looking for the shaft and the tip of the needle. And in that way, you can constantly keep an eye on the advancing needle tip. And if needed to be readjusted, again, you can readjust the advancing needle so that you puncture the vessel right at 12 o'clock. That way you can maximize the successful, the chance of successful cannulation of the vessel. Okay, next step in the 6-step approach is the confirming the needle position within the vein. So once you have the needle tip has reached the anterior wall of the vessel, now look for the needle indenting on the anterior wall of the vessel and advance the needle tip so that the needle tip is within the vessel wall. Then you see this bright spot, just like a tunnel in the light appearing in a dark tunnel. Okay, so once you have confirmed and you've seen this bright spot within the vessel, you are certain that the needle tip is now within the vessel, and you can now aspirate blood, and then you can perform the guide wire, advance the guide wire through the needle. Just to show you what we have discussed so far. Okay, so performing a femoral venous cannulation, you have made the skin puncture. Now you slide the probe and look for where the shaft and the tip is. Then as you advance the needle, constantly slide the probe, keep looking for the shaft and the tip of the needle, and compared to the cannulation of the internal jugular vein, the femoral vein can often be challenging, partly because there are a lot of fat overlying the femoral, the groin area, and that makes the visualization of the shaft and the tip difficult. So you constantly move the probe back and forth to see where the tip of the needle is. And then once you have reached the anterior vessel wall, and if needed any redirection, you can redirect the needle tip. And then you start to you're tenting the anterior wall of the femoral vein, and then you slowly you enter the vein, and you start to see this bright spot within the vessel. And now you're certain that the needle is within the vessel, and then you can progress to perform the guide wire advancement. Okay, once you've done that, the next step is to confirm the wire position within the vein. This is a view from the internal jugular vein cannulation. So you can see that in both the transverse view and the long axis view confirm the guide wire presence within the vein. Now, what I would recommend is, it's not good enough just to look for the presence of the guide wire within the vessel. You want to see where this guide wire is advancing to. So if you have the probe, swing the probe down and look for the brachiocephalic vein. So tilt the probe down. And this is where I find the use of the microconvex probe very useful. So you can, if you tilt the probe and look down into the mediastinum, you can see that's the confluence of the internal jugular vein and the subclavian vein. You may be able to visualize the brachiocephalic vein and the upper part of the SVC. And here you will be able to see the advancing guide wire. In that way, you're certain that the guide wire is heading towards the heart, which is the intended area where you want the tip of the central venous catheter to finally reach at the end of the procedure. Why is it important? Because what we don't want to do after we completed the procedure and do the X-ray is to realize that the catheter has migrated or into the wrong vessel. In this example, the catheter vessel, which was inserted into the axillary vein, has gone into the jugular vein. And similarly, here the catheter which was inserted into the jugular vein has gone into the subclavian axillary vein. So by confirming where the guide wire is going, whether it's going into the brachiocephalic vein, you'll be able to confirm that you're heading in the right direction. And if you're not, you may be able to withdraw the guide wire and redirect the guide wire. Confirm the catheter position in the vein. Again, use a short axis or long axis view. Now, as we get good at ultrasound skills, other ways of confirming the catheter is you can, if you're good at cardiac transthoracic echocardiography, you'll be able to see you'll be able to visualize the superior vena cava by keeping the probe at this anywhere between the second to fourth intercostal space to the left of the sternum, and by angulating the probe slightly towards the right, you will start to see the ascending aorta, and behind the ascending aorta you see the superior vena cava, and there you may see your central venous catheter lying. The other way is using the subcostal view. Here again, using a modified subcostal view, which we normally use for assessing IVC, you'll be able to see the superior vena cava joining the right atrium. So that's IVC joining the right atrium. That's SVC joining the right atrium. Again, by injecting some saline, again you'll be able to confirm. That the vessel, the tip of the catheter is lying in the SVC. That's another example of confirming the presence. You can see that actually the tip of the catheter in the right atrium, and when you inject agitated saline, you see that appearing on the right atrium. Again, another example to confirm the presence of the catheter in the SVC. Okay, just two quick examples of real-time cannulation. This is a real-time cannulation of internal jugular vein. You start with cleaning and draping, and then before you start, again, as I mentioned earlier, use a sterile sheath to maintain sterility, and look at the vein. You should have ideally done this before you start clean and drape. Look at the vessel and decide where you're going to perform the needle puncture. And again, if you look carefully here, the operator is holding the syringe and the needle as described, mentioned earlier in the slide, as you would do in a landmark technique. The disadvantage of this is, look what happens when the operator is making a skin puncture. It completely distorts the image. The completely image goes blank when you do that. So once you make the skin puncture, make sure you constantly look for the tip of the needle, and you make sure you're making an indent on the anterior wall, and then you look for the bright spot in the vein. Here again, the operator did not look for the bright spot by the time he aspirated blood. So these are some things, sorry. Seem to have lost the screen.
Maybe Dr. Kumaresh, you can stop sharing and reshare again.
Yeah, okay. Yeah, okay, stop presenting. Present now. Can you see me now? Can you see the screen? 1 second.
Yep, it's loading.
Okay.
All right. Yep.
Okay, sorry about that. Okay, so in that way you can once you have punctured the vessel, then confirm the vessel position with the guide wire, confirm the presence of the guide wire with the short axis and long axis. Again, this procedure was done a few years ago. At the time, this concept of looking for the guide wire in the brachiocephalic vein was not practiced. So that's something to learn from this practice, from looking at this video. Okay, the next one is just a quick example of axillary vein cannulation. Again, start with the pre-procedural scan. Start with the short axis and then rotate the probe 90 degrees. Look for the long axis of the axillary vein, and then as you can you can also see the lung sliding there. Once you have you're familiarized with the anatomy, you start the procedure. Again, draped aseptic technique. You can see the advancing needle tip. Constantly make sure you're seeing the advancing needle tip. And once you're almost about to puncture the vessel. Once you puncture the vessel, then you can advance the guide wire. If you can see in this one, the puncture needle is a cannula over the needle. So after the puncturing the vessel, the operator removed the needle, left the cannula and advancing the guide wire now. So once you've done this, so now you want to see whether the vessel, the guide wire has gone into the internal jugular vein or not. He's confirmed that, and then he's looking into the brachiocephalic. So as you can see, that's the, if you go back, so here there's no guide wire is seen in the internal jugular vein, and now when he's looking in the brachiocephalic vein, so that's the confluence of the subclavian vein and the internal jugular vein, and that becomes the brachiocephalic vein. You can see the guide wire there. So that way, the operators confirm that that he has passed the guide wire into the right vessel. Okay, so we talked about this 6-step approach. Okay, what other areas where do we use ultrasound for vascular access? We use it for peripheral venous cannulation. We often use it, the catheters we use are either cannula over the needle or modified Seldinger technique. We talked about the anatomy earlier. The preferred site of PICC line insertion is The recommended site for insertion is the arm. Which part of the arm? If you take the arm, you can divide it into 3 areas, which is the middle part of the arm, which is about 7 to 14 centimeters from the medial condyle. That has been recommended as the area for performing a vessel puncture for PICC line insertion. Why? Because the diameter of the basilic vein is the maximum in this area. And also, if you perform it more distally, it may be uncomfortable for the patient, and with the patient bending the elbow, it may cause the catheter migration and may cause some mechanical damage to the catheter. So that's why the green zone is recommended for making vessel puncture for PICC line insertion. The other uses are arterial cannulation, whether radial or brachial or axillary. Sometimes people use it for radial as well in patients who are obese and with a lot of fat. The other uses, emerging uses, is if you're using for cannulation for patients with who require extracorporeal circulation. Using the transverse view gives you an idea about the dimension of the vessel, and that helps to choose the what size cannulas you can use it for the ECMO support. If the diameter of the carotid artery is about 7 millimeter, you use a 21 French, or the maximum you can use is a 21 French cannula, but that will occlude the flow, so you may go for a lower cannula. Similarly, you can use it for the venous cannulas as well. You can decide what is the catheter size, what is the cannula size you are going to use for the ECMO procedures. Just coming to the end, this is just an example to illustrate what happens or how do we manage if we inadvertently puncture instead of, while attempting to puncture internal jugular vein, you puncture, put the guide wire, dilate and insert a central venous catheter. Here you can see the catheter sitting, going through the internal carotid artery into the arch and the tip sitting at the arch of the aorta. Again, depending on the situation, if you have, whether you just made the needle puncture or whether you have inserted the catheter, how you manage will vary. If you have inserted the catheter, if it's a non-urgent situation, leave the catheter in situ, call for, get a vascular surgical or interventional radiologist help. Do not remove the catheter immediately if it's a non-urgent, and remove them in a control setting. Either you can use some vascular device closure devices, or it may need some surgical intervention, because if you remove the catheter immediately, you may run the risk of creating a large hematoma or risk of forming a pseudoaneurysm, and all these complications can happen. So that's how you manage inadvertent cannulation of the vessels. On the other hand, if you just punctured, you can apply external compression. If you used a smaller needle, less than 7 French, which is what most of the needles which we used in the central venous cannulation set come with, so you can apply pressure, but bearing in mind that there's still risk of hematoma occurring, especially if patients has got some coagulation problem. That again will need a follow-up with the vascular surgical colleagues. Okay, so to summarize, we talked about the evidence for the indications of central venous cannulation, the evidence to support the use of ultrasound for central venous cannulation. We talked about how do we optimize the images. We talked about the algorithmic 6-step approach to perform the central venous cannulation in order to perform it safely and to minimize complications. And that brings to the end of this presentation. Thank you very much for your attention.
Can stop the sharing? Yeah. Yeah, Dr. Kumaresh, you can stop. Yeah. So we'll just have a short Q&A session because I don't see anyone asking. So
Vscan Extend, the anytime, anywhere ultrasound solution. It is durable, robust, and built for diverse clinical environments. Vscan Extend can tolerate a 1 meter drop with only minor scratches and bumps expected. The probe cable has a nylon string in its core to protect the wires. Its cover is made with light magnesium alloy instead of plastic to help protect the electronics. Built-in drop zones further protect the electronics. Vscan Extend's bezel edge helps protect against fluid and dust particles. Rely on Vscan Extend to empower you in that critical moment.
all right, so now we start our Q&A session. If you have any questions, do let us know in the YouTube text below. So if you don't have, maybe I can start asking Dr. Kumaresh first. I noticed in your presentation just now, you were using microconvex as one of your, which is not your typical, in NS or critical care setting. So I just want to ask, what is the most common places or vessels you use for the microconvex in your daily practice?
The microconvex for vascular access, I use it for commonly for axillary vessel cannulation. But now increasingly, I also use it to confirm that the guide wire has gone into the correct vessel. Because the microconvex probe, as I mentioned earlier, the footprint is very small. It's very easy to use, and compared to the linear probe, the depth is much. You can see deeper structures with much better resolution with the microconvex probe. I also use it for other obese patients, especially for femoral venous cannulation. Also, if needed, I use a microconvex probe. It's actually one probe which you can use it for everything, not only for vascular access. You can use it for lung ultrasound, even for cardiac ultrasound.
Mm-hmm. Okay. How about if, let's say, I know a lot of the one in your presentation where you say, IGC, central line insertion, ultrasound guided central line insertion. But what if, let's say, we're talking about just normal granular insertion, maybe some needle, blood taking. Is it for you, what do you think of this opening up ultrasound usage to nurses or maybe paramedics or just, basic granular setting? Do you think it's a possible idea to open for them?
It depends on the who's providing the care and the front line. If the care is being delivered by frontline nursing staff, yes, I would recommend training the nursing staff both for cannulation and for other phlebotomy as well. There are healthcare settings like in UK. Some of these tasks are actually carried out by appropriately trained nursing staff, both in the emergency department setting and also in the critical care setting. They call this advanced critical care practitioners, where the nurses have been trained to undertake peripheral venous access, arterial cannulation, central venous cannulation with using ultrasound. Yes, it's possible. It depends on the available resources and how the structure of the healthcare model is.
We do have one question from the YouTube comments. How can we recognize the real tip of the needle in the vein? Because sometimes we misunderstand the artifact of the tip. Yeah.
So as I said, the tip of the needle it usually appears as a bright compared to the shaft. The shaft usually appears less bright and there is a acoustic wind or a shadow, like a comet tail, which usually is seen in the shaft of the needle. But if you use the probe, slide the probe, use this to and fro method, you will see that when the tip, you don't see that acoustic shadow, but you see that in the shaft. I use that the presence or absence of that acoustic shadow along with the to differentiate between whether it's a tip or the shaft. The other important thing is the tip to me is more brighter than the shaft of the needle. And again, by moving the probe, very subtle movements, by tilting the probe, when you move beyond the tip of the needle, you don't see the needle, the tip. And then you tilt the probe back again, you start to see this, the bright spot. So that confirmed to me that the tip of the needle is within the vein. I showed you earlier this bright spot in the dark tunnel.
Okay, we do have one more question. Yeah.
Just to add on to the previous question, the other way you can do is not only you didn't need a short axis view, you can also rotate the probe long axis. You will be able to see whether the tip of the needle is within the vessel.
Okay, got it. Okay, we do have one more question. Do you recommend back and forth retraction of needle during peripheral vascular access to confirm needle tip position, or best to advance needle at one go, slow and steady with ultrasound?
What I recommend is, when I do, is not back and forth of the needle. I do back and forth of the probe to constantly keep an eye on the tip of the needle and the shaft of the needle, so that in order to minimize tissue damage, I slowly, once I make a skin puncture, I move the probe, slide the probe, and see where the shaft on the tip of the needle. Once I'm happy with the confirm, then I move a millimeter or two, again confirm with the probe where the tip of the needle shaft is, then advance another 1 or 2 millimeter. So as a slow stepwise approach, I advance the needle. I don't advance the needle in one go. If I were to do that, I would just use it blindly. I don't need ultrasound. I use the ultrasound for difficult cases. I have got only one chance, and I want to make it best use of that chance.
Okay. So I guess there's no more question. Maybe one last, maybe some advice from you, because I noticed when I travel around, the adaptation of ultrasound for vascular access is still like a very low in terms of practice on a daily basis for ASEAN. So what is your advice to those who are maybe interested, want to learn more?
I think I've been practicing vascular access using ultrasound for the last. I practiced without using ultrasound for 10 years, and then I started using ultrasound. And in the last 15 years, I come to realize that the only reason not to use ultrasound for vascular access is not having the machine. Otherwise, if you have the machine, use it, because it's safe. If I were to use it, if it was my relative, I would want to use it, because I would want to give the best care. And that's the principle I apply to whatever I do. And that will be on my own piece of advice. And second piece of advice is always constantly look for the tip of the needle. Okay, because I see juniors doing it, not looking for the tip of the needle and running into trouble.
All right. So thank you, Dr. Kumaresh. I guess to all the viewers, thank you for joining our session. I guess we'll end our session now. Hopefully, you guys can join again next month, where we have Dr. Sutapon from Chulalongkorn University in Thailand. She's an emergency physician. So until next time on 26th of September, we plan the next webinar. So until next time, thank you and goodbye.
Thank
See
you.
you soon. Thank you, Dr. Kumaresh.
Thank you.